Welcome to the Future of Dermatology Podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
Dr. Maria Aleshin. She is an associate professor of dermatology, co-director of the HS clinic at Stanford, along with Dr. Barnes, and co-director of the inpatient dermatology consult service at Stanford. And she completed her medical and residency training at UCLA. She'll be talking with us about non-biologic therapies for HS.
Good morning, everyone. It's such a pleasure to be here with you all. So as Haley mentioned, I'm going to be talking about non-biologic therapies for HS. Here are my disclosures. So I wanted to keep the objectives very simple. I just hope that you guys walk away with some practical pearls that you can apply in your clinic as soon as tomorrow, or I guess as soon as next week. So we all know that pathogenesis of HS is really complex. We know it's multifactorial. We know that follicular occlusion, metabolic dysfunction, hormone imbalance, dysbiosis, immune dysregulation, and friction all play a role. Fortunately, we have various treatments, whether they're medical, procedural, or lifestyle interventions that can address each of these components. However, we oftentimes have to combine treatments from all of these categories to get patients' disease under adequate control, something known as treatment stacking. When we take a closer look, we see that biologics and small molecules actually make up a very small component of all the treatments that we have at our disposal. However, we know that they are, of course, of utmost importance. So I'm going to be focusing on some of our non-biologic treatments that we can use for patients that have mild, moderate disease on their own, or maybe in conjunction to biologics in patients that have more moderate to severe disease. So we're going to kick it off talking about some topical therapies. We know that a lot of our patients have probably already tried topical washes. This is actually not based on any studies. It's really based on expert opinion. It's thought that these washes have some anti-inflammatory properties. They may help reduce antibacterial resistance. The two washes that we probably most frequently recommend for our patients are chlorhexidine as well as benzoyl peroxide. However, a lot of our patients, up to a third of our patients, are not able to obtain these washes. They can be hard to find in the drugstore. They can also be really expensive. So I went ahead and I did some math, and I found that chlorhexidine and benzoyl peroxide are both pretty similarly priced. However, zinc pyrithione, which is found in products like Head & Shoulders, is about 3 to 4-fold cheaper, and it's actually also included in the North American treatment guidelines as a wash that we can recommend for our patients. So just something to consider. So we're going to jump off talking about our first case. We have a 34-year-old female. She's well controlled on spironolactone and oral contraceptive pills. However, she does experience a new tender flare, and she is reaching out asking what we can do to help her with this flare. And as Dr. Barnes alluded to, a lot of our patients, actually the thing that they care most about is what we can do to help them with their flares. So we can talk through some of the things that we can share with our patients. So about a year or two ago, we sent out a survey to HS experts across the country asking them how they manage flares in their patients. And you can see there's a lot of different things that people do because, of course, there's different types of flares, different severities of flares. But what we see at the top here is that systemic antibiotics are recommended by all experts often or sometimes. And the antibiotics that are most frequently recommended are tetracyclines like doxycycline, Bactrim, Augmentin, and clindamycin. And typically these are prescribed for 2 to 3 week courses. So this is in contrast to antibiotics that we're recommending for 3 months for long-term management, and we'll cover that in a little bit. So I oftentimes will prescribe a course of antibiotics for my patients to have on hand in case they flare over the weekend and they're unable to get a hold of me. Topical resorcinol is another agent that can be helpful for flares. It's an anti-inflammatory, antimicrobial, and has keratolytic properties. It's been studied for flares as well as for ongoing therapy. It's been shown to improve the pain associated with flares and then how long that flare lasts. And it's also been shown to be superior to clindamycin for long-term management. The reason why I use it more frequently for flares is because it can cause some irritation, peeling, and dryness. And it also can be expensive. It has to be compounded. So this isn't something that your patients can just pick up at CVS. You have to send it to a compounding pharmacy, which can cost, $40, $50. And unfortunately, the shelf life isn't that long. So you do have to take cost into consideration. However, a lot of my patients find it extremely helpful, especially for their nodular flares. So something, again, I usually like to arm my patients with so they have it on hand in case they flare. Some of my patients, no matter what, would rather come in person and get an injection for one of their flares. So intralesional triamcinolone has been well studied. It works extremely fast. Some people have improvement within 24 hours. It can be helpful for lots of different types of lesions, inflamed nodules, small abscesses, as well as draining tunnels. Some of the more recent studies suggest that maybe we need to be using higher concentrations of IL-TAC, ranging from 20 to 40. Despite these higher doses, there's actually very low risk of side effects in the studies. A quick reminder where we're injecting. When we're injecting a nodule, we're injecting right into the middle, trying to infiltrate the nodule. When we're injecting a small abscess, we're injecting kind of around the abscess. And then when we're injecting a tunnel, we're kind of aiming right at the base of the tunnel. So consider using slightly higher concentrations of IL-TAC for your patients. Typically, I reach for about 20 mg per cc, and I've injected in all skin types and have been fortunate to not see any side effects. So jumping into our second case, we have a 27-year-old female. She has ongoing flares that seem to get worse around her menstrual cycle as well as with sweating. She has concurrent PCOS, an elevated BMI, and prediabetes. She's already been on some topicals and has done a 3-month course of doxycycline. And you can see here that she has early stage 1 disease. So our patient's wondering, what are some additional treatments that we can offer her to get her disease under better control? So in patients like this, I'm really thinking about hormonal therapies for long-term management. I use a lot of oral contraceptive pills, reaching for ones that combine estrogen and progesterone, things like orthotricycline or Yaz. I learned at the annual AED that there's a birth control called Slind, which has drospirenone only, which can be helpful for your patients that may have contraindications to estrogen. And then just remembering that sometimes folks that are on progesterone-only contraceptive pills, that can actually worsen their HS. I also use a lot of spironolactone on its own or in addition to oral contraceptive pills. When you look at the pooled data, the response rates are about 50%. What's interesting is patients tend to respond whether or not they endorse premenstrual flares. And typically the doses that were studied are about 100 milligrams a day, which is what I usually aim for, but I do occasionally go up to 100 milligrams twice a day if needed. Finasteride can also be used in your patients that may have contraindications to spironolactone or if they're intolerant to it. It's less studied than spironolactone, but you can see in the pooled data about 63% response rate, and I usually do about a 5 milligram dose. So I tend to reach for these agents a lot in my female patients that have PCOS, if they endorse premenstrual flares, but I even try it in patients that may not be aware if they're having premenstrual flares. In patients that I think may have a component of metabolic dysfunction, meaning maybe they have acanthosis nigricans, PCOS, maybe they're overweight, have prediabetes, I oftentimes will reach for metformin. Oftentimes I'm using metformin as adjunct therapy, so I'm adding it on to something else when a patient's already on therapy. It's really safe. It's safe to use in pregnancy. It can help a little bit with weight loss as well. There was a retrospective chart review that looked at over 50 patients, and about 68% of them had subjective improvement. The main side effects I see are nausea and diarrhea, It's quite common, can occur in up to 20% of patients. However, it does tend to get better if patients are able to stick through it. Typically, I'm trying to get to a dose of about 1,000 milligrams to 1,500 milligrams a day, and I up-titrate by 500 milligrams every week. So again, consider adding on metformin in your patients that may have stigmata of insulin resistance. So the patient then asks about isotretinoin. So unfortunately, I haven't had much luck with isotretinoin when it's been used in my patients, and that's kind of what the data reflects as well. Very mixed results, ranging anywhere from 36 to 68% improvement based on the study that you look at. Some studies suggest maybe a little bit more helpful in your younger female patients that may have a history of acne or pilonidal cyst. In my practice, I tend to reserve it for patients that have mild HS as well as severe nodulocystic acne. The way I think about it is even if it doesn't help their HS, at least it's helped their acne, so I'm not wasting time. Acitretin, a little bit more effective than isotretinoin, I would say. The main thing here is side effect profile can be quite high. Sometimes patients don't tolerate it. It's also contraindicated in your female bodied patients that have reproductive potential, but can see some improvement in over 50% of patients, maybe a little bit more effective in your patients that have a follicular subtype to their HS. So not really my first or second line therapy, but something you can consider using in select patients. Botulinum toxin, I mentioned that this patient gets worse with sweating. It's something that I've been adding on as adjunct therapy for some of my patients with mild to moderate disease. We know that botulinum toxin can help with sweating. It's thought to also reduce inflammation and may help prevent follicular occlusion. It's not been well studied. There have been some case series, one randomized controlled trial, and it showed that patients did see some improvement in their HS. There was improvement in pain, improvement in quality of life, and it was actually very safe and well tolerated. So I typically dose very similar to how I would be treating axillary hyperhidrosis. I do about 50 units per area per side. If there's a larger body surface area, I'll go up to 100 units. And I've been fortunate to be able to get this approved in a good number of my patients. So consider adding this on in your patients that may have concurrent hyperhidrosis. So this is just an example of a patient 1 month before and after being treated with botulinum toxin, and you can see that improvement in inflammatory nodule count. Clascoterone cream, this some people have used for acne. It's been studied in HS. It's thought to work locally at the site of application to target DHT. We can see that DHT plays a role in follicular occlusion as well as in some of these pro-inflammatory cytokines. There's one study that looked at 12 patients that were on stable therapy or no therapy, and they only had nodular flares, no tunnels, so folks that had early stage 1 disease. And you can see a good majority of these patients improved, 83%. However, of course, cost is a big issue. So this actually isn't something that I've tried in my patients yet. So moving on to our third case, we have a 45-year-old female who has a history of breast cancer, and she has ongoing flares in her axilla, and that have been going on for the past several months. She's been on some topical regimens as well as some courses of cephalexin. And here in the photo, you can see that she has a draining tunnel, so she has early stage 2 disease. So the patient's wondering, so what are some additional treatments that we can consider for her? So we, of course, she qualifies for biologics, right? She has moderate disease, but in this case, she has a history of breast cancer. She hasn't yet tried a longer course of antibiotics. So in this case, we can think about doing monotherapy antibiotics with something like tetracycline. This is thought to be first line for patients that have mild to moderate disease. Oftentimes in the US, we're reaching for doxycycline twice a day for 3 months. There have been some recent studies that have looked at other antibiotics as monotherapy, but these are all from single center retrospective studies. And then dapsone can also be used as maintenance therapy. I don't use it as often just because of side effects and need for blood monitoring. I wanted to spend a little bit more time talking about combination antibiotic therapy as well. So clindamycin and rifampin are probably the most well-studied antibiotics for HS. Typically, we prescribe them for a 10 to 12-week course. They can be used as second-line therapy for patients that have mild to moderate disease that may have failed doxycycline, or as first-line therapy for patients that have moderate to severe disease. You can see that efficacy is quite high, 70 to 80% based on the studies that you look at. But what you can also see is that relapse rates are really high. As patients come off these antibiotics, 60% of patients can relapse after 4 to 5 months. There have been some recent papers that have raised the question, well, do we need to be giving these two antibiotics together? Well, you guys probably remember from med school, rifampin is a very strong CYP450 inducer. So it essentially is eating away at the clindamycin. So when these two antibiotics are given together, the levels of clindamycin are quite low. So some people are saying, well, maybe let's just do rifampin on its own. But then, of course, there's this concern about tuberculosis resistance. There's also been studies that have compared clindamycin versus clindamycin rifampin, and folks did just as well in the clindamycin alone group. But then when you give clindamycin alone, there's increased risk for C. diff. Rifampin helps decrease that risk. So I've still been prescribing the two together. We'll see if, when the new guidelines come out, if that's still going to be the same recommendation. I do occasionally give clindamycin on its own if there's contraindications to rifampin. So this is my patient at her initial visit, and this is her after clindamycin rifampin, and this is after adding on an additional ILK, and you can see she had significant improvement, and then she later underwent deroofing for that residual sinus tract. So triple antibiotic therapy, this is a combination of rifampin, moxifloxacin, and metronidazole. It's given for a 3-month course, and then in the studies, patients went on to continue just monotherapy with Bactrim or doxycycline. The important thing is you have to stop metronidazole after 6 weeks because otherwise patients can develop neurotoxicity. It's been studied across all stages of HS, but I tend to reserve it for folks that have moderate to severe disease just because the side effect profile can be quite high. You can see 2/3 of patients can have GI side effects. So again, something more like second, third line therapy for patients that have moderate to severe disease. This was one of my patient, early stage 3. We were trying to get her on a biologic. We're not getting it covered. So I put her on triple antibiotic therapy. And you can see she had drastic improvement in her draining tunnels. And then eventually we were able to get a biologic approved for her. So our final case, our shortest case, this is a 27-year-old gentleman, very severe HS, already on infliximab. However, he's hospitalized for a very severe flare. Unfortunately, derm was not consulted. He was instead seen by gen surgery, and you can see he undergoes numerous INDs. So had dermatology been consulted, what are some additional treatments that we can consider for this patient with severe HS? So in this case, I would actually be thinking about ertapenem. Ertapenem is an IV antibiotic. It's a carbapenem, has very broad spectrum activity against gram-positives and negatives and anaerobes. The only thing it doesn't cover well for is Pseudomonas. Because it's given daily, patients do need a PICC line, but they can administer it at home. Typically, the lengths that have been studied are anywhere between 6 weeks to 16 weeks. I usually do it for about 6 to 12 weeks. The important thing to know is patients come off ertapenem, they have a very high risk of relapse and recurrence. So this is really only to be used as a bridge to surgery or a biologic. There was a recent paper that was published that looked at almost 100 patients with severe HS that got ertapenem for 12 to 16 weeks. There was improvement in disease activity, inflammatory markers. Patients were very satisfied. So we know that it works, but we have to really consider the public health implications of prescribing a big gun like ertapenem. So I really do reserve it for my most severe patients as a bridge to something else. So in conclusion, we know that non-biologic agents can play a crucial role in the management of HS, whether we're using them on their own to manage more mild or moderate disease or in conjunction with other biologics to manage our patients that have more moderate to severe disease.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.